morphology of the disease, the amoeboid patterns, the imaging that is done, the different types of imaging, including the autofluorescence, the ICG imaging, OCT, and more recently OCT angiography, laboratory diagnosis, the role of the different tests for TB, the treatment, and especially the treatment response, which is peculiar to Serpiginous-like choroiditis, including the paradoxical worsening, and also a little bit about the persistent inflammation in some of these cases, even after we have given the anti-TB therapy. So these are things that are known, and I'm sure majority of the audience here is familiar with these things. These are not what we'll cover in this talk. I'll cover some of the new insights, and these are mainly from conversation with my fellows. So I have learned from my fellows, and that's what I'm going to discuss with you here. I've divided these into 5 important points. The first 2 are kind of related. The importance of interpreting negative TB tests when you have a very classical morphological picture of Serpiginous-like choroiditis, and I've been lucky to have worked with Dr. Kalpana on this particular aspect. The deception of the response to corticosteroid therapy alone, and that happens commonly when the tests are negative. Then a little bit about foveal involvement and how what we see on the autofluorescence is kind of a tip of the iceberg, which is beneath the RP. Then the visual surprises in Serpiginous-like choroiditis, and finally a little bit on the persistent inflammation in this condition despite anti-TB therapy. So these are all things that I don't think we talk about much in our discussions on this condition. Now, negative TB tests are very common in extrapulmonary tuberculosis because the TB tests that we do, be it the MON2 or the quantiferon TB Gold test, these measure the memory T cell response to the mycobacterial antigens. Nothing more, nothing less. And these may not develop completely in every individual, which is why up to 30% of all cases of extrapulmonary TB can have a negative quantiferon TB Gold test. This is more common in those that are classified as possible than those that are classified as proven tuberculosis. And very importantly, and this data is from a very interesting South Korean study, very importantly, the percentage of patients coming with a negative TB test is the highest in CNS tuberculosis, which we know is very similar to ocular tuberculosis. So we should expect negative TB tests in some of our patients. We think them to be TB. And the thought is more substantiated by this histopathological study that had come from the Armed Forces Institute of Pathology in the US, where they took 42 eyes of patients who had been enucleated for tuberculosis long time ago when there was no proper treatment. And in these histopathologically proven eyes, up to 40% had a negative MON2 test and 57% had a normal chest X-ray. Remember, these are histopathologically proven. So, this should not be a surprise to us. So I'll show you a case here. This was a 48-year-old male who came to us back in 2008. And with whatever understanding of the disease we had at that time, we did a MON2 test, we did a chest X-ray, which was normal. So you can see the lesions here. One lesion is right here at the fovea, which is why he came to us. This is the left eye. Of course, the right eye is completely scarred, so he had already suffered in the right eye, and now, because the left eye vision has dropped because of this foveal lesion, and also there are lesions down below here. There's a scar and activity around it. He had come to us, we tested for TB, and that was negative, so we treated with steroids. He improved, but then came back with a recurrence 4 months later with the lesions at the fovea enlarging in size, and this is where we thought we have to give more steroids, and we did that, and he improved again. But he came back with another recurrence when we thought that our immunosuppression was not good enough, so we treated with azathioprine along with steroids, and you can see how the lesions are gradually covering the entire macula in the only seeing eye of this patient. Of course, as expected, he improved again. You can see the lesions going away, they are scarring a bit, and this is when he got tired of us and was lost to follow up. He came back to us 4 years later, and this is the picture. Almost the entire fundus in the only seeing eye is now involved, and by this time we were a little wiser and we knew what was going on. So despite the negative test, we treated this patient with anti-TB therapy and oral steroids, and he has followed up with us for almost 15 years now, no recurrence since then. Another case which is a little more dramatic, of course it's not exactly serpiginous, but still tells you the story. You see these two choroiditis lesions in the right eye, temporal to the macula, as well as in the left eye. And this patient came to us in 2018 when we did the TB tests again, including a CT thorax. TST is tuberculin skin test, which was negative. And since these were negative, we treated this patient with steroids. The lesions disappeared. You can see 6 months later, clean both eyes. Only the old scars remain. And then the patient goes away only to come back to us after another 6 months, which is in the June of next year, September next year. And you see the size of the lesion over there, a huge granuloma sitting out there. If the patient comes to me today, I would have done both the quantiferon and the MON2 test at the same time, not because one is better than the other, but sometimes one being negative, the other comes positive, and that gives you a better handle to treat these patients. I mean, but this was some years ago, 6-7 years ago, and that time we went back to the history of the patient, and we found out that he was a migrant worker living in the Gulf states, and he was sharing the accommodation with multiple people. And this is where we suspected the possibility of a TB contact. We started the patient on anti-TB therapy alone. Okay? And this is the picture that happens after treatment with only 2 weeks of anti-TB therapy alone. The lesion is melting away, and in 5 weeks, gone. No steroids, completely gone. So patient with negative TB tests and a normal CT scan of the thorax, this could be the picture. So negative tests with a high pre-test probability of this being tuberculosis has a chance of being false negative. So that concept should be there with our mind. We did this study a few years ago with Dr. Kalpana's group, and we had 15 patients of Serpiginous-like Choroiditis who had both negative MON2 and quantiferon TB Gold tests, with a median delay to presentation of at least 10 months. And in these patients, 13 completed anti-TB therapy, and there was no recurrence after completion of anti-TB therapy in 12 of these patients. So we have good evidence to treat these patients. Now you saw in both the cases how giving steroids can give you an initial resolution, and that is a deception, and we should be aware of that. And for that I took this picture from different stages of presentation of this patient with classical Serpiginous-like Choroiditis kind of presentation. The tests were negative, so one of my colleagues treated this patient with steroids and later with azathioprine. But you see what is happening. At presentation, there are these active lesions which are involving the fovea. We treat this patient with steroids. At 3 months, the lesions disappear, and you think that your steroids alone are working. Of course, there are a lot of naysayers who will tell you that serpiginous has nothing to do with TB, and those people as well will treat this patient with steroids and immunosuppression. And you do get a good result in the initial stage, but as you follow up these patients, you see at 6 months and at 18 months how the macula gradually gets involved. And this tells you how steroids, the initial response, can deceive us into believing that this morphology has nothing to do with tuberculosis. This patient lost vision from 2025 at presentation to 2080 at the last picture that I'm showing you at 18 months. So from the issue of the negative TB test and the deception of steroids, we move on to the foveal involvement. Here I want to highlight that Serpiginous-like choroiditis is essentially a choroidal disease, and the RP involvement is only secondary to the choroidal involvement. So the imaging the RP, which is usually done by autofluorescence, may underestimate the true extent of the disease, which may be better found by ICG angiography or by near-infrared imaging. And this is very well shown in this picture, the only available evidence of histopathological status in serpiginous-like choroiditis, where we see that the inflammation is primarily involving the choroid, the full thickness of the choroid, and besides the RP. So you have to look at SLC as a choroidal disease rather than the RP, which has been the highlight all these years. Now this patient you see here came to us with serpiginous-like choroiditis, which is not very obvious in the picture, but also with retinal vasculitis. Now if you look at the autofluorescence and you compare it with the ICG finding, you see that the ICG finding is way more extensive than what we are seeing on autofluorescence. The fovea is not exactly involved on the autofluorescence, which is not the case on ICG. And this is also seen when you look at the near-infrared imaging. The image is a little fuzzy, but it also tells you that the fovea is getting involved when you look at the NIR image. 3 weeks after anti-TB therapy and steroids, you see the NIR image, how the fovea is still involved. And if you have treated adequately, then these lesions will not progress, and you will keep thinking that the fovea is uninvolved in these cases, whereas you see on the ICG that it was. Another case where we have the autofluorescence and the NIR image next to each other, and you see that the autofluorescence might make you feel that the fovea is uninvolved. All the lesions are away from the fovea, but when you look at the NIR image, you see how the lesion has gone very much into the fovea. This is a very interesting case that shows you what actually happens in these patients, and you see this patient came to us with this choroidal granuloma over here, and we have done the autofluorescence. It shows the involvement of the RP over the area of the granuloma. Also see the granuloma in the OCT over here. Now, when you follow up this patient comes to us after 1 week. You see that in 1 week, the granuloma, we had not started any treatment by then because, sent for the investigations and all. So he just came back to us with the reports after 1 week. You see that the choroidal granuloma is now resolving on its own. We have not given any treatment. Whereas the RP now and the outer retina has started getting involved over here. Okay, and this is so this shows the natural course of the disease. And then when we follow up this patient, we start the anti-TB therapy and the steroids, you see how the serpiginous pattern is appearing over the choroidal lesion that you see here. So it shows how the serpiginous pattern develops over the choroidal lesion with the passage of time. If the patient presents late, then you don't have this discrepancy. Both the lesions, the autofluorescence and the ICG, are matching each other. You can also have a lot of visual surprises in serpiginous-like choroiditis. If you look at the two pictures over here, the right eye seems to be involved much more than the left. But if you look at the vision, the left eye vision is 20/200, where the right eye is seeing 20/20. So the visual status may not match the clinical appearance. Look at this patient. Look at how both the eyes are scarred at presentation, 20/200, 20/250. You do an autofluorescence, you see the entire thing is hypoautofluorescence. Are you going to treat this patient? Can I have 2 minutes? Yeah. So you are not going to treat this patient, right? Entire thing is hypoautofluorescent. but we went ahead and treated this patient with anti-TB therapy and steroids. And you see the outer retinal atrophy on the OCT as well. So we went ahead and treated with anti-TB and steroids, and you look at the picture after 9 months. Appears very similar to what it was before, but see what has happened to the vision. Okay. Vision in the right eye has changed from 200 to 2080, and the left eye from 250 to 2050. No change on the autofluorescence. Now see what has happened on the microperimetry. This is a patient who came back to us last week, and on the microperimetry, you see that there are multiple areas where the retinal sensitivity is very well maintained. And if you compare the right eye and the left eye, you see that there are better areas of retinal sensitivity in the right eye as compared to the left. And in fact, despite having a 20/80 vision in the right eye, he was feeling better symptomatically in the right eye as compared to the left eye, which was 20/50 on paper. So these are the nuances in the management of SLC that we need to understand when dealing with these patients. Last thing about persistent and recurrent inflammation, I think there are more questions than answers. I really don't have a thing to tell here, but we have to make sure we are dealing with TB. I had a very nice case on atypical mycobacteria causing a SLC-like lesion. Couldn't bring it here. But make sure we're dealing with TB and not missing on an alternative diagnosis. Drug resistance is relatively rare, and some of these cases have to be treated with immunosuppression and local steroids when there is persistent inflammation. So this is the last case I'm showing you. Came to us in 2017, had a negative test for TB, was treated with oral steroids and azathioprine. You can see the autofluorescence here, and kept on having recurrences till 1 year later we realized that this has to be treated with anti-TB therapy, and he received a full course of anti-TB therapy. But even after a full course, he comes to us 2 years later with this diffuse scleritis. Now all of us have seen these kind of cases, and then that was treated with symptomatically, but then in 2020, 2 years later, he comes to us with this lesion on nasal to the disc, which is a new sclerochoroiditis, a nodular scleritis with involvement of the choroid and the overlying retina as well. This time we treated with anti-TB therapy. Initially we gave NSAIDs alone, but later on, because of the disc edema, we added oral steroids, and the patient recovered well with no recurrence for the past 5 years since the second treatment. So we really don't know what is happening in these patients. Is it just an immune-mediated phenomenon, or is it something more to this is yet to be understood. So these are some of the new frontiers that we discussed: the negative TB test, the steroid deception, the foveal involvement, how it is a tip of the iceberg that is in the choroid, the visual surprises, and the persistent inflammation despite the treatment. Thank you very much.
Thank you, sir. Thank you, sir, for that insightful talk.